Hi, good morning and welcome to the latest ECIST podcast. My name is Angela Russell. I'm an improvement manager from the Emergency Care Improvement Support Team, and I am joined today by Charlotte and Joe to talk about catheter care. Charlotte and Joe, would you like to introduce yourselves, please? Charlotte?
Yes, so hi everyone. So I'm Charlotte Sumnall. I'm a community nurse fellow on secondment at the moment with NHS England. However, my background is I'm a district nurse and I'm a clinical matron at North Devon Hospital.
Wow, really busy. Gosh.
Yeah.
And Joe?
I'm a urology nurse specialist background for approximately 20 odd years. I've always done urology, and I've just taken a secondment as a urology nurse specialist catheter champion. So working across the community and the acute trust for Mid and South Essex hospitals and the ICB.
Gosh, that's brilliant then. So we've got two different areas as well, from geographical areas as well. So that would be really, really helpful to have that experience. So thank you both for joining us today. That's fabulous. I've got 4 questions, if that's okay, please, to run through with you. So probably the first one directed at both of you. So Joe and Charlotte, why are you here to talk about urinary catheters today?
So part of the work that I've been doing as the annual community nursing programme, we commissioned a health economist to look at hospital activity data across the East of England region, and we found that UTIs were in the top 3 reasons for ED attendances over the past sort of 6 years. So that made us want to think a bit more around how we manage urinary catheters in the community. Being a district nurse by background, I think I know that they can be managed in the community, and the community can struggle with some of the complexities that I think people don't always think about in when it comes to catheters. But we've got 90,000 people living with urinary catheters across England. And we also linked some data with the urgent and emergency care. And we found across the East of England that it's the second highest reason catheters are for patients using urgent and emergency care. Mm-hmm. We also know that approximately 50% of UTIs are catheter related, and actually 30% of patients with indwelling catheters do not have a clear indication for why it's in use. So that's sort of what's brought us here today. And I think Joe could probably talk about why she was placed as a catheter champion within Mid and South Essex.
I think there was some really forward thinking sort of from us at ICB and Mid and South Essex hospitals, and they saw that obviously the risk of having a catheter in increases every day. Bacteria can increase 2 to 10 days each time, and every day a catheter is in, the 3 to 7% increased risk of infection. There's been some serious incidents in the community with patients being discharged with catheters, which is why they've brought me in to look at the risks associated and try and decrease the use of urinary catheters and improve care for patients.
Just for some people that are listening that may be interested, where does some of this data come from, just out of interest?
So it's a mixture of hospital activity data. Okay. There's other statistics that we found within sort of articles, and also within place data within the community. So that's where sort of we found, and we're doing deeper dives. At the moment, we found data across the East of England region because that's where I'm sponsored within the national team. However, we're currently in the process of scoping what that looks nationally, but we already are having quite strong indications that it's quite similar nationally to regionally. And then I can let Joe come in from her point of view.
I think there's lots of research around it. The British Journal of Urology is highly documented in their articles, and across, not just across the region, but across the country, it is highly recognised.
Yeah, that's really helpful. Thank you.
And I think also to say that when patients are going in and using urgent and emergency care, and then if that results in them being admitted, for our older patients, we know one of the risks of being admitted into hospital can lead to deconditioning. So it's also those other things, other indications or other risk factors of someone being admitted with a catheter isn't just resulting in UTIs. It's that deconditioning that we know can happen to our older patients.
And that's where we would work seamlessly together then, to be able, in terms of the emergency care improvement support team, to be able to, you know, stop that deconditioning and everything that comes with increasing mortality and, you know, muscle wastage and everything else as well. So that's
especially when it's something that could be managed in the community, and community staff are very au fait with managing catheters.
And they really want to do it as well.
Yeah, exactly. Yeah, we don't want people to go into hospital.
So how does urinary catheters impact then on patients and their families and quality of life? That's probably
do you want to come in?
To both of you. Jo, do you want to start?
So I think it has a massive impact, especially sort of if you know, you've got a mobile for all patients, but if you've got a mobile patient that comes into hospital, never had a catheter before and is discharged, it affects their daily activities of life. It's embarrassing, it can be painful. For elderly patients going home with a catheter, you know, they may not be able to deal with this. It's an extra thing to deal with, and it's quite restricting on their life, not only sort of just having a catheter inserted, but some of the trauma that it can sort of introduce. So patients get bladder spasms, leakage from around the catheter. They can get urethral trauma and sort of end up with other problems associated with the catheter. And it's just, it affects all aspects, even sort of sexual function. And we've had a patient embarrassed to talk about the catheters come to a clinic and really wanted to get that catheter out. And the main aspect of that was because of his sexual function, and that plays a really big part of his life. So just by getting the catheter out, teaching them even self-catheterization, which is an alternative, gives them back some independence and quality of life.
And I think, you know, when I was nursing as well, back years ago, when I was an A&E nurse, we used to get patients in and we used to get them sorted and obviously move them on. And a lot of the times we'd catheterize patients, and it was very much part of their treatment. But actually, there was a huge psychological backstory to that as well. And I think one of the things that I noticed, and I was, you know, I was in my mid-20s. I was really, you know, for me, it was quite staggering to notice the impact that had on patients as well. It was really, you know, that invasive procedure by somebody, you know, being touched in that way. It was really difficult for them, and, you know, everything that went around it. So that was a huge learning point for me as a nurse.
Yeah, and I think it's not to be underestimated how much it affects day-to-day life, down to what kind of clothing they might want to wear when they go out. You know, we have a tradition that I'm not quite sure where it's come from, that we encourage all patients to have a leg bag and not even to use the flip flow valve. And you think having a leg bag, whether they're short, long, you know, they either can go on your thigh or on your leg. If you're a lady, you know, the likelihood of wanting to wear a skirt or a dress will then change, and then you might be wearing trousers, but actually if they're quite tight fitting trousers and your leg bag's starting to fill, then, you know, people can see that. So I think, you know, those kind of if you can just imagine it yourself, you know, I had a catheter fitted when I had my child. It was only in for 12 hours and it was really uncomfortable, and it made me realise actually how people must deal with that all the time. And I was just in hospital and I managed to, you know, ask for it to be taken out really quickly. And I think we need to think about how we can empower our patients and our patients' carers to ask the question and say, why have I got this catheter in? Does it need to stay in? You know, it is up to, you know, we have a responsibility as professionals to review that, but also I think it's really important that we have those conversations with patients and think a bit differently. You know, is there something different? Is there a different way we can help to support our patients?
So what we do a lot of the time in ECIST is, rather than saying to a patient, what's the matter with you? We say to a patient, what matters to you? Yes. Very similar wording, but very different question. And you get an awful lot more back from the what matters to you, because what matters to me might not matter to you, Charlotte, or matter to you, Jo, but it's that whole holistic mindset that needs to be taken into account.
Yeah, I think for younger patients as well, we had a gentleman that went to a nightclub with a catheter, and because there was noise, he went to the cubicle, and because there was noise in the toilet, a bouncer knocked the door down because he thought he was on drugs. He was doing drugs. So,
How
and
awful.
the psychological impact that had for that patient was just, astronomical.
Huge.
Yeah.
Something like that you'd never get over almost, would you?
No. And then trying to make him compliant with the catheter and sort of having a flip flow valve, making life easier for him. But it was, it really did have a huge impact.
Yeah. And I think also for our older patients, I'm a huge advocate for older people. And I think they're already a group of patients that are at risk of social isolation and loneliness.
Yeah.
And then we seem to pop a catheter in, and that reduces it means they end up staying at home even more often because they don't want to go out. They don't want
it's the
to
logistics.
the logistics of going out. What happens if it leaks? Can I go on the bus if it leaks when I'm on the bus? And
dexterity is not the best if you've got arthritic fingers, or if you as you get older. And it is just that whole catalogue of issues that I think are often overlooked.
Yeah, definitely.
So come on then, Jo, tell us about your role as a catheter champion, please.
So it's a really important role. It's improving communication between the community and the acute trust. And I think it helps. We've developed sort of multidisciplinary meetings where the community nurses can attend if they've got a patient that they're concerned has got a long-term catheter and has got issues, and it highlights, we can discuss care around that patient. We've also got a lead consultant, so if there is any queries, he can overlook the case. And it's about sort of starting from the basics, really. It's educating staff, educating patients, because I think one of the biggest things, if a patient has got a catheter in, they're sent home and they I don't know how to deal with this. And I think giving the patient that education and that contact of somebody if there is a problem is really, really important. We're looking to develop catheter ward rounds to question as to why a catheter's in, to see if we can't reduce the number of catheters on the ward. And one of the ways of doing that is by implementing the Houdini framework. So it's making nurses be able to have that autonomy to say, why is that catheter in? Can we get it out? And it's really important, but it's the enablement of the staff and the patients to be able to deal with this. Introducing catheter passports, which has been a directive for a long while, but doesn't seem to always take place, but giving the patient a catheter passport that they can keep for themselves and bring into hospital, or show their community nurses as to why they've got that catheter in. Hopefully in the future this will become electronic, so patients can have electronic access. If they haven't got an electronic device, then they have got the paper form. But the biggest thing is sort of the education with the acute and community trusts.
So you've got some amazing initiatives there. So like the Houdini, I didn't know what the second word was, but what was it? The Houdini
framework.
Houdini framework. Is that a localized framework, or is that something, because forgive my ignorance, or is that something that could be rolled out? Because I mean, something like that, real key, snappy thing like that would make people think, is it just local to where you are, or is it?
No, so it is sort of well known, but not many places are using it. And it's just an acronym. So Houdini stands for hematuria, obstruction, urology surgery, defibrillator, input and output, nursing end of life care, and immobility. So there's a checklist. If the patient hasn't got any of those from the acronym, then it's thinking, can we get that catheter out? Is there an alternative? Can it be managed? If they've got incontinence, can this be managed with pads? Can it be managed with self-catheterization? So it's just making sort of staff aware to try and get that catheter removed.
I love that. I love the Houdini. I've never heard of it before, and I think that's fantastic. So definitely something that we could champion on our way round.
I think the other thing is we're looking at sort of implementing a guide wire catheter. So this has been a small pilot within our community. The guide wire catheter has been developed from UCLH, and it's, if patients can't be catheterized in the community by a district nurse team, the pilot has shown that they can use this indwelling guide wire catheter, and it stops the patient having to attend A&E. So admission avoidance is the real big thing, trying to stop those patients coming to A&E.
And do most sites and systems have catheter champions? Is that something that, you know, a catheter champion's routinely used and known about?
So it's quite a new role, and when I researched sort of for my interview process, there was only one, and that was up in Newcastle. So it is a really relatively new role, and it's, you know, it is very forward thinking and just concentrating on those, you know, catheters. Yeah,
brilliant.
And I think what I like about the role that Jo's doing is it's not just from one organisation. So it's an ICS approach, which means we can bring those systems together. So bring in, you know, better communication between community and hospital, but also across the whole ICS, which hopefully the idea is that patients won't necessarily have as much of that postcode lottery of, you know, I live in this area, but I went to this hospital and things are maybe a bit different. That I think we've had probably has been our constraints at times. I don't know whether Jo would agree in her urology position that you've been in.
Yeah, definitely. And I think as being a urology benign CNS, it's, yes, you deal with catheters, but there's so much else going on within your workload. So to have this just to concentrate on the catheters and sort of patients and families is really, really important. And I think trying to improve them communication links with the community has been valuable. So, and it's looking at sort of teaching in the community as well. So looking at what they've got in place for teaching and education.
Brilliant, thank you. And Charlotte, can you tell us about what you're doing nationally then to support community nurses and patients with urinary catheters, particularly this winter and then in the future also?
Yeah, so we started off by developing a regional catheter network group that was around looking, similar to what Jo said, is looking at that sort of, you know, best practice, shared learning, how do we promote education, and sort of bringing everyone together in the region, which is how we sort of met Jo and was able to see the fantastic work that Jo was doing. But then myself and my colleague Safiso really thought, okay, well, what impact can we make this winter? Because all of the things that Jo is doing is fantastic, and it's great to be able to, for us to be able to see that deep dive and, you know, eventually see the inputs and the outcomes from that. But we're not at the point to be able to spread that nationally. So what we've done is we've looked at what is the best practice that's out there. So our aim this winter is to ask community nursing services to stop, check catheters. So the idea is we've got the acronym of check, which is around consider, using that Houdini approach. So that's the H that Jo's just talked about, to say, does that patient need a catheter? So if they don't need the catheter, let's see if we could, let's TWOC them. Let's you know, follow the pathway that we know is out there that can TWOC them. And if we think that there's 30% of catheters out there, indwelling catheters, long-term catheters that aren't needed, I'm not saying we'll get those 30% out this winter, but if we can get 10, 20% out, that would have a huge impact. But then if your patient, if you followed that and your patient still needs a long-term indwelling catheter, it's then thinking about that escalation, communication as to, you know, does your patient have a catheter passport? You know, what does your patient's care plan say? Do your patients and the family members have an escalation plan? Do they know what they need to do if things go wrong, so that then they're not accessing urgent and emergency care, and hopefully they're being able to access their community nursing teams. And if the community nursing teams have got sort of good care plans in place, hopefully they can manage people, you know, hopefully we won't come across as much crisis management. And that isn't to say that, you know, we'll always have those crises and those emergencies that are required in catheters. But like I said, we want to do those sort of further regional deep dives. So Jo is an example in Mid and South Essex, what they're doing, but we're looking at some of the other services across the east of England that we know they're doing community TWOC-led clinics, you know, seeing, and that it's like a one-stop urology shop, they call it. So the idea is to look into, you know, what are they doing and what impacts does that have? But also, if we bring all of that together and we can look at the national data and sort of probably a bit more of a deeper dive into the regional data, actually, is it that we need a national strategy to manage urethral catheters, to manage them better in both community and within the hospital? And that might be something that we can take forward to, you know, to Ruth May's C&O team to say, you know, we've identified this is the problem, this is what we've done this winter, but actually long term, what else do we need to do to keep it sustainable and to make further change? So that's sort of our plan at the moment.
Perfect, thank you. Jo, anything else to add from your point just on that one?
I think it's just such an important thing, and I think the biggest thing is to avoid those patients having to come to hospital, and I think if we can do that, you know, it's a win-win for patients and also everybody.
And it's about linking that best practice. So as well, we've linked in with a catheter specialist at Southampton University who's linking in with our regional group. Maybe, I don't know if you've ever heard of a CAT group, so it's a critically appraised topic. So the idea is, if when professionals come together, if they can highlight one topic that they think they don't know enough about, you know, we need to know the literature a little bit more, then you know, you work with a university and you do sort of a small literature review, you look at what the literature says, you look at what happens in practice, and then the idea is within a region you can come up with a solution that works in practice, so it's not just evidence-based. So that's something else that we're hoping to do over this winter, and we can then see what the outcome of that is. So it's mixing that regional deeper sort of learning, and then how can we how can that transfer nationally?
How can you roll it out?
How can you roll it out?
Practice?
Because we know with catheters, you know, just because you live in the east of England, your catheter's not going to be any different whether you live in Essex or whether you live in Devon, where I live, or you know, it doesn't matter, does it? A catheter's a catheter. So you know, how can we look at it from a national point of view?
Perfect. I think we should use that as our strapline for today. A catheter is a catheter, and how do we look at it from a national point of view? Brilliant. Thank you. So thank you both so much for your time today. It's been really interesting and really helpful, and loads of stuff that even I as a nurse didn't know, and up-to-date information, and the data and the statistics I think speaks for itself alone. So thank you very, very much for that. Really, really grateful. And we look forward to seeing the next podcast in the series. So thank you.